Okay, good afternoon. Today's program is an entirely different approach to this idea of bridging, but not exactly, because here the emphasis is going to be to a considerable degree on incredible technologies. And they're sort of like the opening of a big door, which one presumes is not closed, but is going to continue to have new developments and new ways of visualizing. So, where is my colleague? Jeff? Okay. So I was thinking over the weekend, what are the great advances that have taken place in science and their application to medicine in relatively recent? I guess that depends on how old you are. But it seemed to me that clearly microbiology, the discovery of organisms, viruses, and so forth in the antibiotic era has got to be one. The development of biochemistry, which led to understanding metabolism and revolutionized endocrinology and other areas. The human genome, which is increasingly leading to sophisticated genomics and beginning to understand the role of genes in biological processes and disease, and certainly molecular biology, which moves closer to putting things on a mechanistic level. So if you visualize these as all as circles, there's obviously enormous overlap one from the other, but it seems to me that the one dimension of extraordinarily exciting development that embraces all of these fields is the concept of imaging, the dynamic nature of seeing things as they are. Now, we're going to have a session later in this course on what you might call small imaging, or at least imaging of small things, if you consider a cell as a small thing, and molecules, clusters, viruses. So that's coming up in early May. But today the focus is on imaging big things, things that most of us, unless you're dealing with patients or with animals, most of us are concerned with more reductionist elements, cells for the most part. But to image the function of an organ and the organization of how cells in an organ create those functions, to be able to detect disease before the patient even knows they have it, or if they have it, to define exactly where, how much, how bad, to evaluate therapies, to scan using genetic probes. This is an enormous area that is far from something that is static. It's dynamic as can be. And so today we're very fortunate indeed to having two colleagues from the clinical center who are going to discuss and present sort of the state of the art and perhaps some projections of the future of this kind of what I would sort of euphemistically call large imaging. So the first of our two speakers, the first will be David Bluemke, who, it's interesting, each of our colleagues began studying physics, or in his case it was chemical engineering and then physics, and then he received an MD PhD degree from the University of Chicago with a PhD in biophysics and theoretical biology. He then went to Johns Hopkins, where he took training in radiology and where he became more deeply involved in imaging. So David is Director of the Radiology and Imaging Sciences at the National Institute of Biomedical Imaging and Bioengineering. That's here. His main area of work has been in cardiovascular disease, and I think that will be the major topic of his presentation today. And so our second speaker is Ron Summers, who is an MD PhD student from the University of Pennsylvania. He started out with an interest in physics, which seems to be a prerequisite for ultimately working in the imaging field, and then took medical clinical training, radiology training at the University of Michigan, and then studied MRI technology and experience at Duke. Ron came to the NIH in 1994. In the year 2000, he received one of the Presidential Early Career Award for Scientists and Engineers, one of these prestigious things that's given by the Office of the President of the United States. And his fields include areas like virtual colonoscopy, tomography, multi-organ registration and development of large image bases and their application to clinical problems. So we're very indebted to both of you for taking the time to be with us. And I guess, David, you're the first speaker. And so David is also, we have a patient who will describe his illness shortly too. Thank you.
Okay, thank you very much for the introduction, Wen. And I like your analogies in the discussion of the role of going reductionist and then patient level. And one of the things that we'll be talking about at the end of this is going beyond the patient to study some of the new topics, especially in genetics, are going to require large groups of patients in terms of tens of thousands, hundreds of thousands. And that's sort of where things are heading, and some of this will be at the beginning, very beginning portion of that. When we look at the role of imaging, as Wynn indicated, certainly when you think of the most impactful developments in the field of medicine, usually imaging is on the top of that list. And this is a recent survey that was done indicating the prominence of MRI and CT. And there's been a tremendous number of advances in genetics and stem cell therapy and so forth. But these truly make a difference on a daily basis to the patients. This is an example of one of the latest generation CT scanners, if you haven't seen this for a little while. There's an X-ray tube in here. The patient is lying on the table, and in about 10 seconds the entire body is scanned, and that will result in three-dimensional images in that period of time that can be reconstructed in a number of formats. So I'll just give you a little bit of introduction where we are now in some of these machines. This is a new machine we got about a year ago or so at the NIH. It was the second one in the country. It combines a traditional MRI scanner using magnetic fields and magnetic technology with molecular probes based on PET positron emission tomography. And that's combined in one of the, in this instrument, all at the same setting. There are now about 10 of these instruments in the United States so far, and the idea is to combine the anatomic and functional MRI, for example, with molecular techniques that we have available. In terms of applying these to cardiovascular disease, clearly the role of cardiovascular disease in the United States is very prominent. These are the rate of cardiovascular disease deaths related to cancer, almost a 2-to-1 ratio as the population ages. And the economic impact is tremendous. The last time the tally was taken, over $400 billion spent on health diseases and coronary heart disease, stroke, hypertension, and heart failure. In this area, the most rapidly growing component. Now, if you think about the causes for these conditions, a lot of it's under our own control. And these are things that we can take care of, but nevertheless, the society as a whole has these problems in spades. So if we think about the problem of high cholesterol levels, treated by statins very successfully, hypertension, also very successfully treated, but about 30% of the population in the U.S. still is hypertensive. And then the epidemic of obesity affecting about 2/3 of the population as overweight or obese in the United States. This becomes a transgenetic phenomenon, so this is going to be something that's going to be with us for some time to come. So one approach may be to take these high-tech tools, and these are CT scans, some of the anatomy that may be causing these problems in obesity, and maybe it's this portion of the middle portion there that's causing it all. And so that's one way to do it. Those images are from a medical student who's at Cornell at the time, and we had a display of his images at the NIH Clinical Center for a while. But this is a patient. This is a chest image where the heart and the great vessels have been removed for viewing. And this is the ascending aorta, the blood vessels going to the arms and the brain here, and then the descending aorta going around. So tremendous three-dimensional visualization of these structures. But it goes well beyond that because this is very adaptable. So this is the initial CT scan view of this patient where the front chest is shown. We can see the ECG leads here. This patient had a myocardial infarction, which we'll talk about shortly, and then had recurrent chest pain. So by using the same set of images, we can reformat this to look at different portions of the body. A common problem causing chest pain is costochondritis, pain at the rib junctions anteriorly, or we can peel back further. This patient also happened to have a pneumonia, which turned out to be incidental. Same image set, we can reformat to look at the rib cage, and here we're now getting into the left ventricle. And we noticed a small abnormality in the ventricle. Again, reformatted, same images, same CT scan reformatted to find this excrescence on the surface of the ventricle, and this is where the blood is. So this is blood that's kind of sticking out here. And if we take a cross-section through the left ventricle, which is here, this is the muscle of the left ventricle, this is the right heart, this is the cavity that contracts. We see this excrescence here, and this person had a myocardial infarction inferiorly, and this infarct is about to rupture. The heart, after you damage your heart, it becomes very soft, and if the blood pressure is not controlled, then this can be ruptured. So this patient was emergently sent to the operating room, and this was repaired. Most patients, unfortunately, die with that condition. So it's quite clear, because of the speed, the ease of access in the United States, this is going to be changing the care of cardiovascular medicine, especially over the next 10 years. And these are sort of coronary angiograms that are obtained. These are the coronary arteries. This is the left anterior descending coronary artery. And here you can see the plaque buildup in the proximal LAD. And when that ruptures or gets irregular, a thrombus can form, resulting in a myocardial infarction. But the motivation is generated by the images. The diagnosis is generated by already tens of thousands of patients studied with these techniques to show that they're extremely effective and capable in finding early disease in patients who may have just mild symptoms. Now, CT is outstanding at showing anatomy. When it comes to showing function, this is an image of the upper abdomen. We can see the liver and spleen being perfused with blood. To do this, we had to take multiple images of the body over and over with X-ray. And there's some obvious disadvantages to taking multiple moving images with CT, and primarily that of radiation. These are the lungs showing breathing motion. So what about radiation, and where do we sit? Well, a radiation worker, Dr. Summers and myself, we can have a certain limit working around these radiation-producing devices of about 50 millisieverts. Patients who undergo these diagnostic invasive procedures have an exposure that's somewhat less, up to 20 millisieverts typically. But when CT started coming out, initially taking pictures of the heart, the radiation doses were quite high, and since this is non-invasive, the patient could have multiple exams. So it was quite a concern that the radiation dose would build up over time. And we've seen New England Journal and JAMA articles over and over about these high radiation doses. But in truth, the radiation doses now have the capability to be reduced to less than 1 millisievert, extraordinary anatomy that can still be demonstrated in patients. So it's become, with the latest technology, much less of an issue. On the other hand, if we're going to generalize the studies in terms of very early stage disease, where individuals are no longer patients, but really we're looking at asymptomatic individuals, the problem of radiation is something that we probably don't need to and don't want to expose our study participants to, if possible. So in terms of cardiovascular MRI, The initial applications were only of the sickest patients would get these tests. They'd have every other test in the book, and finally they would perhaps have an MRI when everything else failed and wanted to see what was really going on, as in this case. This patient came into the emergency room with chest pain. There was a suspected mass in the aorta, the abdominal aorta. So I removed the heart here, and this is the ascending and the descending aorta, and you can see this mass in the descending aorta. Based on some technology that was partly also developed by Dr. Zerhouni before he was at NIH, we put part of the MRI scanner actually inside the body to image from the inside out. And this is an antenna that's placed in the esophagus. The esophagus is very close to the aorta, and we could see very high resolution detail of this mass. And then doing additional images, we decided to more or less fly into the aorta in this relatively sick patient using 3D reconstruction and visualize the mass in the aorta and its adherence to the aortic wall. This is going down towards the feet now at this point. Well, eventually this mass was removed. It was an adherent blood clot in a patient with protein C deficiency and protein S deficiency. And ultimately this had to be removed. The thought was if that breaks off, that patient would lose a leg, would become an amputee. So clearly the sickest patients, that was the initial application of this technology. And I just want to introduce our patient example for today. This is Mr. Joseph Beffin. If you would come up to the front, we'll talk a little bit about the use of the technology of cardiovascular imaging. Have a seat. And I'm not sure if I'm supposed to have a microphone here as well. I thought we'd talk a little bit about something a little bit maybe more routine, which is the evaluation of myocardial infarction. Yeah, I think it's on now. Okay. So something that you see on TV all the time, individuals who have a heart attack, it doesn't always quite work like that. But luckily we're very successful in treating these conditions. And so I'd like to just start with Mr. Bevin and ask him about when you had a heart attack in the year 2000.
Yes.
I just wanted to ask you about the symptoms that you had when you first thought you were not feeling right that day.
Okay. I did not have any of the symptoms that you normally hear of. Didn't have any chest pains, didn't have any numbness or anything like that. I woke up on a Saturday morning, was in bed about 7 o'clock. I got out of bed, and I wasn't feeling the way I normally would feel. And I thought, well, maybe I'm going to throw up or something. So I went in the bathroom, and I felt like I needed to throw up, but I didn't. And after about 15 minutes, I decided, well, I didn't do anything in diet or anything that would cause it, but something was happening, and I didn't know what it was. No pains, no aches or anything. So I went down, got dressed, went downstairs and told my wife, Faye, drive me to the hospital. I want to get checked out. Which surprised my wife. I had never asked my wife to ever visit a doctor with me or drive me anyplace, let alone drive me to a hospital. But she consented and drove me to the hospital. So I went to a hospital, and I told my wife to park the car, and by the time she got inside, I went up to the counter, and I knew what would happen. They'd want me to fill in a lot of paperwork, so I told the people on the other side of the counter, I think I'm having a heart attack. I figured that would get me the most action in a hurry. Immediately a wheelchair came up, a doctor came out right away. By the time my wife got into the hospital, I was already being rolled into a room where they gave me an EKG or something. And they told me I had had a heart attack. I didn't know I had it, no previous training to have one, just that I have one. And that started everything into motion.
Do you happen to remember what medication, how did they treat you at first? This is at a community hospital that he went to.
Okay, well they said based on the test they gave me I'd had a heart attack. They gave me something, I forget what it was, to thin the blood to give me an increased circulation in the heart. They weren't telling me them what they were doing, but they were doing something. But later on I found out they gave me something to increase my blood circulation, and it helped. Now, since I wasn't in pain or anything, I didn't know what was good, bad, or indifferent. But the doctors felt that it was helping. So I was there in the hospital. They were treating me. the best they could, but they didn't have all the equipment they have now in this particular hospital. It was here in Maryland, not 2000, so they elected to transfer me to another hospital where I could have more tests done and see what they could do to increase my chances of recovering from a heart attack.
Yeah. So you should probably amplify that a little bit, because there were a couple circumstances that you were very lucky on. Number one is feeling indigestion is not typical. On TV, it's tearing chest pain radiating to your arm. And so you were very lucky that you said those buzzwords. So if you go to an emergency room, there are buzzwords, really, I think I might have a heart attack, I have the worst headache of my life. They're things that get you past the counter right away. Right. And that's one of them. The second thing, so that's at 7 a.m., by the way. So around noon, he had a TPA, a blood thinner, anticoagulants were administered. And the symptoms really hadn't gone away, actually. You weren't having a lot of chest pain, but they could tell on the EKG the problems were not going away.
Yeah, if it wasn't for the machine, I'd have got out and walked out of there.
So there's one other circumstance that made you very lucky to get out of there and get to another hospital.
Yes.
And that was?
Well, my daughter showed up. My daughter is very persuasive. My wife was standing here alongside of it. But my daughter, you do not say no to her. And she had conversations with the doctor, and first they thought she was a doctor because she understood medical terminology, which I didn't.
A little closer.
And so they elected to transfer me from there to another hospital. And I got transferred to another hospital from Howard County General to Johns Hopkins by helicopter. And that was the best part of the day. I had a 12-minute helicopter ride, only about 150 feet above Fort McHenry, so I saw the city. And 16 minutes from the time I left Howard County, I was at Hopkins. Within 10 minutes, I was in an examining room where they were performing other tests.
Yeah. So we might mention, just out of interest in that, it helped probably your daughter's an attorney, so that also got you a little better service, perhaps.
Yeah, and her specialty, among things, medical malpractice, medical equipment, but she does defense work.
So she knew sort of the words to say. So there are a lot of lucky factors, because by the time you got out of there, it was actually 8 hours after the initial symptoms. And some people probably in this room might have done experimental occlusion models of muscle, and the muscle doesn't really last that long. Even in animal models that have really good circulation, a 2-hour occlusion is a pretty severe injury at that time.
Yeah.
So 8 hours later, you're at Johns Hopkins, right. And they...
and about a half hour after I was at Hopkins, they were putting a stent in my heart.
Yeah. And
that, I guess, maybe made the difference.
Yeah.
Otherwise, I wouldn't be here talking to you today.
How many stents?
Pardon me?
How many stents?
Okay, I had a stent. This was Saturday around probably 2 or 3 o'clock. They put a stent in. They woke me up Sunday morning about 5 o'clock, asked how I was feeling. I told them I'd be feeling better if they let me sleep longer, but since they asked me, I told them. I told them I felt that I had a burning sensation on my right shoulder under the skin. And then they had that little group of the 5 doctors would talk, and they'd look at me, and they said, I shouldn't have that. So they elected that afternoon they were going to put another stent in, which I was agreeable to. So they did that. They also put in a balloon pump to help my heartbeat. So they did that on Sunday morning. Had a second stent put in and a balloon pump to help my heartbeat. And that's, again, I'm thinking everything's working anyway, but to them this was making it work very well. Yeah. So Sunday they did that.
So I'm not sure if you know what an intra-aortic balloon pump is, but when individuals have a large heart attack, the heart is stunned. It doesn't know how to contract anymore. Its blood supply is damaged. We restore the blood supply with stents, but it still doesn't know how to contract properly, and it's called myocardial stunning. And so a large balloon, I'll show you what it looks like in a moment, it's about this long, goes into the aorta, and it allows the heart to rest. And the third lucky thing for you was that you had a very astute cardiologist who was there. There's no real proof at the time in 2000 that these were really useful. But he thought this would be the best thing to let the heart rest a little bit. And he put that in for 24 hours, took it out before there were complications. And that seemed to sort of provide some opportunity for the heart to recover its stunned appearance so it could take over contracting more on its own at that point.
Right. So I only spent a day in that room, the intensive care room. Then the next day they transferred me to another room, and I was walking in the halls at Hopkins the next day. And then the following Friday, it started on a Saturday. Friday, I left Hopkins, went home, feeling good after walking in the halls for 3 days, and everything seemed to work out fine.
Okay, so you did really well, remarkably well, and I'll show you what everything looks like in just a moment. And then you did really well until really just a couple of years ago. In 2011, you had some shortness of breath.
Right. And I went to a doctor, and one doctor I went to recommended some kind of inhaler, and that didn't work. And then I found out I was actually putting more fluid in my lung, so I visited my cardiologist. I was having dinner with the doctor one evening, and he says I shouldn't wait. So I saw him the next day. He looked at me and looked at what inhalers I was taking, stopped taking that. He wrote a prescription for me, and within 24 hours, in other words, the problem at that time, I could hardly breathe. I would take a half a breath and cough. My sleeping the previous 3 days was in 30-minute segments. In a night, I'd be getting maybe an hour's sleep. I could hardly even walk around. Within 1 day on this new medication, a diuretic or whatever it was, I was able to breathe, and within 5 days, I was back almost to normal.
Yeah.
Just in seeing my cardiologist and getting the right medication, and everything worked fine.
Okay. So I'm going to show some of your images now, and we'll go back. I'll go back to the slides.
Okay.
Any questions for those kind of symptoms? So
what medications are you taking now?
How do I feel now?
Medications.
Medication.
Oh, I take, I don't have a list.
That's
Do
okay.
you know what they are?
Yeah.
Okay. Why don't you tell them, because I forget what they are.
The list is extensive, but typically patients with heart failure will get something to make sure blood pressure doesn't go up, to take the strain off the heart. So there's a beta blocker or an ACE inhibitor, depending on heart failure status. Initially, it'll be a beta blocker to keep the heart rate down, and an ACE inhibitor. Most patients with large aneurysms will get beyond Coumadin after they get discharged as well, to avoid blood clots in the infarct area. And then other medications will be kind of weaned in and out. Yeah. So, okay. So why don't we go? I'll show you what this looked like.
In case anybody was wondering, I'm 77 years old.
Okay, so these are sort of the technologies that are available to us now to look at the heart. You'll see a kind of a cross-section. This is the left ventricle shown in 3 dimensions, and in each cross-section we could look at each element of the heart and the way each point in the heart works. So if you have a new therapy, that may not have an overall improvement in ejection fraction, but we can measure very small areas in the heart to make sure that those are working properly. Let's see. Now, the heart is sort of shaped like a football or a prolate ellipsoid, and so we can take these cross-sections through the heart, and if we take those cross-sections, you get these series of circles. This is an MRI scan showing the images of the heart, cross-sections of the heart, and it allows us to identify the area of the myocardial infarction very precisely. To within less than a gram of tissue can be identified. And the infarct inside these circles are all the white tissue. So those are the areas that initially are dead muscle, and eventually at this point it's turned into a fibrous scar. And this is holding the heart together. It's repaired itself. And by allowing the heart to rest initially, it allows this scar to form so that the heart doesn't weaken and dilate out. But so this is very readily done now. We can do this in 10 to 15 minutes for patients to identify for the first time, very easily for people who haven't seen images, or students, medical students, can really identify the infarcts. Now this is an aortic balloon pump that was placed. These are quite long. This is a chest x-ray. And this will act opposite to the heart beating. And this device, we believed, added an extra ability of the heart to recover and rest during that period when it really wasn't contracting very well and couldn't contract on its own because it had this stunned condition of the muscle where it needs to rest and then recover function over time. You can see the length of these devices from the diaphragm basically up to the aortic arch on a chest x-ray. And that was when he got out of the hospital. Initially, if you're an individual, if you have bronchitis in the winter, first thing you're going to get a chest x-ray, and he was diagnosed as having a pneumonia. And eventually through several different physicians, and then we got a little bit more involved, and it turned out that all of this was related to heart failure. So if you do have a large infarct, the tendency in the United States right now, many people are surviving, and the natural progression is a slight dilatation, and ultimately the heart can't keep up with the fluid. And so this fluid on the CT scan is building up in the lungs posteriorly. A small dose of Lasix, and you start feeling really well. The other time you were prescribed Lasix, I know, is going out for crabs to avoid the salt. An extra dose will keep you eating crabs in the summertime. Okay, so those were the sickest conditions and the most elegant demonstrations of very severe disease in a couple situations. Now, the area that we're going to go to just in a couple minutes, we're quite involved with, is instead of imaging people more or less after they have their clinical disease, what are the earliest symptoms of disease or internal signs of disease that can be identified? And this concept is now, well, instead of taking your most expensive technology, using it on the sickest individuals, what if we put that on us? And what can we see in us in imaging healthy individuals? So here's one example. Now these patients are not entirely healthy. They're relatively healthy for diabetics. But Dr. Turkbay did this study and found in about 1,000 diabetics these small scars that were forming in the heart. These white dots are areas of fibrosis and scar, much like as if you would cut your hand and form a little scar in those areas. And this has been followed up in a more recent study. These are truly asymptomatic individuals, 3,000 individuals from across the United States. Now we have every sort of genetic testing, imaging testing to look at the correlates and the reason that these scars in the hearts will form. These essentially are silent myocardial infarctions. In the United States, it looks like about 5% of individuals at around 65 have these silent MIs that we don't know anything about. In other parts of the world, it looks like it's even higher. There's a study published out of NIH in Iceland. It's substantially higher, maybe 15%, perhaps based on their environment there. Well, if we can start to study a very large number of individuals, then perhaps we can determine the genetics and the determinants of change in the myocardial structure over time. So if we just look at the size of the heart, this is how much the heart weighs in grams of tissue determined by MRI. We can see the function here. We can see that in different age groups, basically the heart shrinks quite dramatically over time. And these are new findings. We used to think that the heart tends to enlarge and dilate and get to an end-stage disease. But in our current population in the United States, that's not happening. We can look at other factors. Just as a simple example, how does body fat affect heart size? And there's a curve for men and a curve for women. As the body fat goes up, we will see that the heart size might increase a little bit, but what really happens, and especially as you get old, as a general response of the myocardium, you can see that the cavity here, this is where the blood is, that gets substantially smaller as we age. The myocardial mass goes up, and this is called adverse myocardial remodeling. It becomes a stiff, thick, small heart. And this is a common endpoint of really the aging population, or to other insults such as smoking and obesity in this case. Now, you may have seen this interview on 60 Minutes. This is Steve Kroft interviewing LeBron James here. And we know tremendous amounts about the physiology of our superstar athletes. They get MRIs just because they wake up and their elbow hurts. We have to know exactly what happens. So the ultra-star athletes we know a lot about. And what we don't know so much about is most of us and how we do in response to exercise. This is LeBron James hitting one of his half-court shots there. It's not the sort of thing that you and I do, but what we do is, what is the response in the normal population to exercise in terms of the cardiovascular system? So once you start studying hundreds or thousands, or eventually we'll be studying tens of thousands of individuals, we see that low levels of exercise, 20 to 30 minutes, as we heard on, actually starts to have a markedly beneficial effect with a steeper slope of the curve. Your heart mass goes up at this portion, but the cavity, the volume of the heart, goes up in direct proportion. There's nothing that's out of whack here. Now, if you're an ultra-marathoner, things go down the other way, and you start injuring your heart, and there's a plateau effect here. And so ultra-marathoners and ultra-athletes are studied very frequently, and so we know a lot about what happens to them. But most of us are on this far end of the curve. And I'm sure most of you remember the physiology. The more you exercise and become fit, your cardiac output tends to go up a little bit. You have a little more muscle mass, but you do it much more effectively. Your heart can pump more effectively with a larger stroke volume. If your cardiac output is almost constant, then your heart rate can go down. That's why heart rate is such a good indice of cardiovascular health. And if you look at how this decreases very rapidly, 30 minutes of exercise, taking the stairs and so forth, then you see that that curve directly mimics NHLBI data in terms of the performance of exercise and reduction of the relative risk of death in individuals. So it's just a little bit of an introduction to sort of the population-based applications, going from our sickest patients now to large individuals, where we will, of course, look at the genetic susceptibility of a lot of these individuals, as well as environmental influences on cardiovascular disease. So I'm going to stop with that short introduction. I think MRI and CT of the cardiovascular system, and heart in particular, over the next years is going to continue to revolutionize the evaluation of cardiovascular disease. And I'd like to acknowledge many of my collaborators here, as well as thanking Mr. Joe Bevan very much for coming here and sharing some of his symptoms and stories today. Thank you very much.
Loudly so folks listening can hear you.
Yes.
But, we hear a lot about the cost of medical care going on. I'm concerned about extrapolating this technology to the healthy people. Do you have any feel for what kind of costs we're talking about if you apply these diagnostics in a healthy population?
Yes. That's why, in part, when we first started studying the population, this was actually very radical. This happened in about 1998, 1999, and it was an NIH idea. And at the hospitals, at that time, MRI scanners were not really all that accessible to most patients anyway. And I was reviewing this actually with Dr. Zerhouni at the time, and I said, yeah, we want to study, at that time it was about 20,000 people with MRI of their heart. And he was really busy, and looked over at me and said, why do you want to study all these normal people? Well, it turns out we're not all that normal. The population has tremendous amounts of occult disease. And the whole goal of the NIH and the concept is treating disease very early before it becomes clinically manifest. So that becomes potentially cost-effective, but probably more cost-effective, you're right, when you find maybe a lower-cost effectiveness tool. You may use high-cost, sophisticated devices initially. But then something like an echocardiogram, if you know what to look for, you can use low-cost, office-based devices and other tests to look at the earliest signs of disease and symptoms of disease.
So should a patient who has an acute myocardial infarction as diagnosed by EKG have an MRI?
Well, it depends. We certainly have been investigating and evaluating the use of it for that. Most patients with heart attacks don't have the size of the injury that we saw today. And it's a 2 or 3 stay in the hospital, and your insurance company will be calling, asking you how you're doing. Is it time to go home yet? I think what happens is when we have individuals who have complications in the hospital, and when there's unexplained symptoms relative to what's going on with their disease status. Those are the individuals who start to get further up and up in terms of the high-tech imaging, what's going on, and why is that present. Yeah?
Can you explain how the balloon pump works?
Yeah, the aortic balloon pump operates opposite. It gets synced to the heartbeat, and when the heart contracts, to the extent that it's contracting, the balloon is deflated in the aorta, so the blood can flow by. And then when the heart is not contracting, it will add an extra pump of blood. It'll inflate. It'll push blood to the legs and arms and to the brain, also to keep everything perfused. So it acts in two ways. The blood pressure is typically reduced during these episodes, and low blood pressure is not good chronically for the brain and organs. So by increasing the perfusion of the organs, we keep renal function going, we keep brain function going. And it's sort of an opportunity for the heart to rest a little bit. A lot of it's empirical, and the clinical studies for the routine use of the devices have not been conclusive. And I think part of that is the sophistication of certain cardiologists who know when this can be used, when is the ideal time to use a device such as this. And now there are other devices, such as left ventricular assist devices, that can also fulfill this function.
So are we to leave people with the idea that if you just don't feel right in the morning, and
Well,
I mean, where do you draw the line?
Yeah.
You kind of implied that the television image of sharp precordial pain radiating down, I mean, that does happen,
yes.
but is it the majority of patients?
Well, there's two
who-
circumstances we should really know about. First of all, I think things were quite lucky, kind of knowing your symptoms and how well you're feeling. For women, the symptoms of a heart attack are typically nonspecific and don't follow the TV rules at all. So nausea, vomiting, diarrhea, those can be symptoms in women. So yes, definitely, in at least half the population, it doesn't follow the rule book anyway. I think in men, the people who survive certainly have symptoms that we recognize. The people who don't survive, which is about 40% of patients do not survive their first heart attack. They will have the acute clutching chest pain symptoms. But we have to really work up those diseases, those conditions in the emergency room. One of the options, I'll just put a plug in for one of the new NIH programs. NIH is looking into studying acute diseases in the emergency room, and I understand there's a new program or center to do that specifically because of the high cost of looking at patients in this emergency setting.
So are we going to see a day where there's a little box that someone can use to put over a precordium that might give an MRI image?
I'm not sure about an MRI image, but the problems are so critical to the population that from a number of point of views, the tests for looking at cell death now, the troponin release, high sensitivity troponin tests, are so good that we'll be able to use those tests, probably avoiding imaging in many cases. Or in some cases, maybe a third of patients. There's another third of patients where the tests are a little bit inconclusive. And right now, it looks like we'll be doing CT scans at advanced hospitals for the inconclusive tests. And if the CT scan is negative, it's about a 99% probability, better than clinical assessment, better than other tests, that you're fine, you can go home. And so that can be done very rapidly, an hour or so, a couple hours assessment, you can go home and know that you're not suffering a heart attack. So I think it'll be a combination of very rapid, hopefully biomarkers that'll come out a little bit more rapidly than we have now. And indeterminate patients, probably about a third of patients have tests where they're held overnight for about 24 hours right now. We'll try and decrease that so people can go home and with knowing what's going on. Are they okay?
Any other questions? Yeah. Please.
In most cases, when somebody comes into an emergency room before they have a MRI, have they been given a sonogram or other imaging before you see them?
Yeah, actually, the most common tests are simply an ECG and blood serum markers. If they get admitted, if there's been a determination of myocardial infarction, they'll get an echocardiogram to look at the heart function and determine how much of the heart is damaged, to have some approximation of how much is going on. If the initial assessment is indeterminate, in probably about a third of cases, they'll be held overnight and they'll undergo more sophisticated testing the next morning typically, because otherwise you'll have all this expensive equipment and people around in the hospitals. So usually it's safe to keep people overnight to do the more sophisticated testing in the morning. And that will be a CT scan, it'll be an MRI scan, a nuclear medicine scan, something like that, that can be a little bit more precise in determining what's going on. Or by the next morning, some of the next lab tests will come out and we'll see what the status of the patient is. Yeah. So you have to really work yourself all the way up to some of these more exotic tests.
Do you think it will be a help for the early diagnosis when the patient have the heart attack symptom? Go to the emergency room, just do the ECG, and to rule out the heart attack will pick up the heart attack rate better?
Yeah, in a circumstance where you have kind of typical symptoms, if a typical history, maybe the patient has diabetes, maybe they have other risk factors, they might smoke, and everything is adding up, and the ECG is positive, the serum biomarkers come back, the troponin levels indicate that the myocardial cell has been damaged, then that's all that needs to be done. As it turns out, that's not all that frequent a situation when things work out that well. And a major cause of malpractice and problems in the emergency room with physicians is the concern that they're sending somebody home who's having a heart attack and it wasn't diagnosed. It turns out there's a standard for that, and it needs to be less than 1% of patients need to be discharged and then actually have a heart attack come back with symptoms again. So that's the level of legal certainty, let's say, that needs to be there. And there are about a third of the patients who have come in very obvious, about a third maybe indeterminate, and another third have to be studied for about 24 hours to see what's going on. Yeah.
Okay, well, there'll be time for more discussion and comments after Ron Summers. Thank you.
Can everybody hear me? Okay. So it's a great pleasure to be here today, and I'd like to thank Mr. Bevan for coming and sharing his experience. My goal for this half of the session will be to give you a flavor for some of the many things that we can do with radiology imaging today, not just in the laboratory, but to take care of actual patients. So I think most of you are aware of the great transition that has occurred in radiology and imaging diagnosis, where we've moved away from to a great extent from the projection image of the chest X-ray to the cross-sectional image of the CT scan, such as this CT scanner that Dr. Bluemke also showed. But what you may not be aware of is that these CT scanners continue to improve, and that it's not uncommon today for a patient to have a CT scan that consists of over 1,200 images, like this stack of images through a patient's abdomen and pelvis. And it is this transition in the CT imaging technology from the early days to today's scanners that can obtain that many images that allows us to do a lot of 3D modeling of different parts of the body that we weren't really able to do that well before. And so in this presentation, I'm going to go through a potpourri of various different applications of what's possible to do with our present-day technology. These are standard scanners that are available in many, if not most, hospitals in the United States. And some of the things I'll be describing are using CT scanners to detect polyps in the colon. This polyp, just to give you a sense of scale, measures about 1 centimeter or less than half an inch. Automated assessment of the bones, like these bones in the spine. Bone mineral density assessment for osteoporosis imaging. Small bowel detection, which may have some use in inflammatory bowel disease like Crohn's disease. Organ analysis, such as the liver, shown here in blue, the spleen in green, the kidneys in yellow and orange. Tumors in organs, like these tumors in this kidney, shown here in red. And finally, lymph nodes in the body, like this one that's highlighted in purple. This is a very important issue for patients undergoing treatment for cancer because the cancer can spread to the lymph nodes, and it's very important. And a very frequent cause of imaging is to try to assess what has changed in these lymph nodes with treatment. So in this presentation, I'm going to give you a head-to-toe tour of the human body, showing examples of the different types of things we can do. And in the last couple minutes, I'll talk about some things that we're doing here at NIH, and I'll explain this acronym RESIST, which has to do with tumor measurements. And I'll conclude with a novel application that we've worked on that uses crowdsourcing and the internet with imaging. So I'm sure in this lecture series there have been other speakers talking about the amazing advances that have occurred with functional magnetic resonance imaging and improving our understanding of the brain in this decade of the brain. And so I won't spend much more time than this slide looking at the brain, but it is possible to investigate not just the skull and the bony structures of our heads, but also all the blood vessels that feed the brain and feed tumors, for example, this tumor here. And so this has been an area of tremendous advance and is easily the subject of weeks of lectures about all this. And much of this work is going on here at NIH. Let's move a little further down from the head now into the chest. And these are images of the lungs and the windpipe or trachea and other airway branches, and these were all obtained from CT scans. And the neat thing that we can do with CT scans is we can take that stack of images that I showed you earlier and we can display the images in all sorts of different ways. So I'll show you some of those different ways. We can look at the lung surface as an opaque model like this, or we can make it semi-transparent so that we can see the structures inside. And we can also isolate the airways. And one of the things that was actually developed in part at the clinical center back in the late 90s was a technique called virtual bronchoscopy, where we took a stack of CT scans through the lungs and created 3D models of the airways like this one of the windpipe or trachea. And then we were able to make these fly-through movies of the airway, which helped us non-invasively look at the airways and evaluate things like metastatic disease to the airways. This can also be used to look at patients with asthma and can also be used to help pulmonologists biopsy lesions that are just outside the airway. So there are commercial technologies today that enable you to use an image like this one that I'm showing you to help guide a bronchoscopist to put the bronchoscope down into the airway and then put a needle out through the tip of the bronchoscope through the wall of the airway and puncture the wall and biopsy something on the other side. So these are things that happened all within the last decade. Here's some other examples of things we can do with pulmonary imaging, different displays, looking at airways and blood vessels. These can be helpful for looking, for example, for clots in the lung, also called pulmonary emboli, and for looking at nodules in the lung and assessing their response to therapy, which can be helpful for metastatic disease. Something that is potentially useful for many patients is automated assessment of the amount of abnormal fluid collections in the lung, like this pleural effusion. And in one of the images that Dr. Bluemke showed, Mr. Bevan had a pleural effusion, and it's possible to precisely measure the amount of that fluid and even to assess what the impact of that fluid is on lung function. There are other diseases that can cause abnormalities of the lung parenchyma or tissue. One example being studied at NIH with this very long and hard to pronounce name is lymphangioliomyomatosis. This is a relatively uncommon disease, mainly affects women, but can also affect patients with a disease called tuberous sclerosis. And this disease leads to abnormal or dysplastic smooth muscle proliferation within the lung that can cause difficulties aerating the blood. And these are techniques using CT scans to identify the extent of abnormality of the lung, shown here in green. Another disease is lung fibrosis, and this can be due to a number of different problems, including smoking, various genetic diseases, viral infections, and some drug treatments. And in this example, the fibrotic lung is shown in red or pink here and can be quantitated and again followed as the patient is treated with different drug therapies. A couple years ago, you may recall there was a pandemic of this viral pneumonia called H1N1. This was also called swine flu at the time, and in this group of patients, we looked at the amount of affected lungs shown here in red and quantitated that and evaluated the patient's response to various treatments. This is one of the earliest analyses of lung disease in this patient population, and that work was done in part at the clinical center at NIH. So Dr. Bluemke has already talked about the heart, so I won't go into more detail about that, but suffice it to say that's another great area of work. Let's move now to the breast. And breast cancer is the second leading cause of cancer death in women. And many investigators have been looking at the use of MRI to help evaluate breast cancers. This patient has a cancer in the breast here. And what we do there is we inject a contrast material into the patient's bloodstream, and that contrast material is taken up by the tumor. And then when we plot that uptake of contrast material and the washout of contrast from that tumor, we can ascertain something about the vascularity of that tumor. And again, this can be useful for distinguishing different types of breast lesions and response to different treatments. And later in this presentation, I'll show how that can be used for prostate cancer. So this is an area that's of great interest and has been applied to more and more different types of disease. So let's move a little further down now into the abdomen. And we're going to talk about some of the abdominal organs. This is a coronal image. So we're looking in this vertically oriented plane parallel to the front of my body. And we're looking here at the different organs in the abdomen. And the patient's right side is on the left side of the picture, which is the standard way that radiology images are shown. This is the liver. A bit of the spleen is up here. The two kidneys are here. The stomach is up here. Here's the spine. And here's the large intestine and pelvic bones. So let's look at the different organs in the abdomen and see what we can learn about them using these techniques. So of interest to many clinicians and investigators is assessment of liver volume. Hepatomegaly is the term for an enlarged liver, and that can occur in a number of different diseases like fatty liver, cirrhosis, glycogen storage diseases, myeloproliferative diseases, hepatocellular cancer, hemochromatosis, and amyloid infiltration. There are also diseases that can cause the liver to get smaller, such as those that cause fibrosis, including cirrhosis. Spleen volumes can be measured in patients with leukemia and lymphoma, myelofibrosis, thalassemia, and storage diseases like Gaucher's. So lots of different diseases in which the liver and spleen size are abnormal. And here are examples of livers and spleens. This is the spleen here. Here's the liver. And the computer has automatically found the edges of this liver in 3 dimensions and has measured the volume of this liver. And this works even when part of the liver has been removed. So in this patient, the right hepatic lobe, which used to be over here, was removed because the patient had a tumor. And the left lobe has enlarged in a compensatory way. And so it's possible to continue to measure that liver size. Here's an example of a liver with metastatic disease in it. These dark areas are areas of tumor, and it's sometimes useful to assess what fraction of the liver is involved by tumor. And here's an example of an enlarged spleen that can be measured, and that's very helpful for some of the diseases I mentioned, such as the lymphomas and leukemias. So there are a number of active protocols here in the clinical center. For example, patients with chronic myelogenous leukemia treated with a new tyrosine kinase inhibitor, are being investigated. And one of the ideas there is to assess the total burden of tumor in this patient by measuring the tumor in the blood, the tumor in the spleen, and the tumor in the bone marrow. Other diseases being investigated are X-linked agammaglobulinemia and autoimmune lymphoproliferative syndrome. Another area that's of great interest is liver tumor treatment using less invasive techniques. And here in this work from the NIH Clinical Image Processing Service in the clinical center, we show the vessels of the liver. So this is the liver here. And the different colors are the different blood vessels, the portal veins and hepatic veins. And then at the end of this movie, you can see the tumor, which is this orange structure. And this is useful because one of the evolving treatments for some of these tumors is called radiofrequency ablation. And in that technique, an interventional radiologist puts a probe through the skin into the liver and burns the tumor so as to destroy it. And one of the issues with that treatment is that you want the heat from the treatment to be confined to the tumor and not destroy the normal tissue or be absorbed by the normal tissue. And one of the ways that's done is by trying to understand where the vessels are, so not only that you don't injure the vessels, but also that the blood flowing through the vessels doesn't take the heat away from the tumor that's under treatment. So moving on to another application, ovarian cancer is one of the major causes of cancer death in women. And often ovarian cancer is not detected until late in the disease when the tumor has spread throughout the body. And ovarian cancer can spread in very unusual patterns throughout the abdomen because it can spread inside the peritoneum. And one of the things it can do is attach to the liver and spleen. So in these images, this is the liver in green here, and the tumor is in red. And one of the things that we're working on is developing techniques to automatically identify those tumors and measure the volume so that when the patients undergo treatment, we can have some idea of whether they're improving in response to the therapy. Another organ of interest are the adrenal glands, and in one study in the clinical center, we're looking at adrenal disease in patients with polycystic ovarian syndrome, an endocrine disease that can lead to hirsutism or excess hair formation, amenorrhea, and infertility. These patients also have elevated androgen levels. Here are the adrenal glands on the CT scan. This is the liver. Here's the right adrenal gland, the left adrenal gland, and here's the left kidney. And these adrenal glands are very small, but their size can change as the disease process changes in the patient. And so we're looking into whether detecting abnormalities in these organs can improve patient care in this subpopulation. Let's move on to the kidneys. Here are the kidneys. There's the right kidney here, the left kidney, a bit of the liver in red. Kidney tumors can occur. It's another major cause of cancer death in Americans. This is a set of kidney tumors in a population of patients with von Hippel-Lindau, a genetic disorder that can lead to the formation of kidney tumors. And here are the kidney tumors that have been reconstructed from a CT scan. And this slide shows how the appearance of the kidney tumor varies as we look at different phases of the contrast injection. So these patients start out with a scan before we inject them with the contrast material. That's this picture here. And then after the injection of the contrast agent, the kidney starts turning white and the tumor does as well. And then later in the scan, we see the whole kidney turning white as the contrast material is concentrated by the cells within the kidney on its way to being excreted through the urine. And one of the things that we found was we could use the contrast behavior of the lesion to this contrast agent as a way to distinguish one different type of kidney tumor from another. And starting with an unknown lesion, we're able to separate the benign and malignant lesions and then subcategorize the malignant lesions into these subcategories like von Hippel-Lindau and Birt-Hogg-Dubé and so forth. Now, just looking at the shape of these lesions, they all sort of look alike. So these are 5 different types of tumors from 5 different patients. And from their shape alone, we can't really figure out what's going on with them. But by analyzing what happens to them after the contrast injection and even over time, as we see these lesions change over time, we can get an understanding of the growth rate of these tumors and figure out when to treat them. Now, you might ask yourself, why would we watch a kidney tumor over time and leave it inside the patient? Well, it turns out that for these kidney tumors, for some of these kidney tumors, it's been shown that there's no need to remove them before they get to a certain size threshold. And it's not until after they reach that threshold that they're likely to spread or metastasize. So what happens is we try to predict roughly when the tumor will reach the threshold size, and then that would be the time that surgery would be scheduled to remove the tumor. Okay, now let's move on to the large intestine, or colon. Colorectal cancer is the second leading cause of cancer mortality in Western nations, and most colorectal cancer arises from polyps or small growths in the colon. A polyp is the size of your finger or smaller. It's a small growth, and a large number of people have these polyps, but the vast majority of them do not lead to cancer. But there's a small number that do. And the way to find those polyps is through screening tests like colonoscopy or colorectal blood tests like fecal occult blood testing. Unfortunately, a lot of people don't get these screening tests. And right now in the U.S., about 40% of Americans over the age of 50 do not get one of these tests, even though it's recommended by the American Cancer Society and other health agencies. There is a test that's been out for about 10 years called virtual colonoscopy, which uses CT scans to help find polyps in the colon. This technique is becoming increasingly available, although there are some issues with that test that are still being worked out. In virtual colonoscopy, the patient undergoes a CT scan after a bowel cleansing and insufflation or filling of the colon with either carbon dioxide gas or room air. And then we make a 3D model of the colon like this one, in which the polyps appear as an indentation of the model shown in red here. And here's an example of a 6 millimeter polyp, probably about the size of your little finger, the tip of your little finger. This is a colonoscopy image of that polyp, and here's what it looks like on the CT scan. So you can see that the CT scan can't tell you what the color of the surface of the colon is, but it can show you shape abnormalities like this polyp on this fold. And here a computer has found this polyp. So the idea is that we would be able to screen people with this CT test using low radiation dose techniques, and with the aid of these computer programs that can help find these very small polyps, we should be able to reduce the incidence of these polyps that turn into cancers. One of the things we're working on is trying to get rid of that unpleasant bowel cleansing preparation, which patients have to take for a period of about 24 hours before they undergo the screening test for colonoscopy and for virtual colonoscopy. And in this technology, we use the computer to electronically cleanse the colon or electronically remove the residual fecal matter, which is shown here in white. This is this residual stool. This black area is the air inside the colon. And on the right, the computer has removed all the stool so that we can now see the surface of the colon. Even if there was a polyp underneath some residual stool, like this one, we can remove it and see the polyp a little better than we could otherwise. So that's something that hopefully will be available in the future to reduce the incidence of colorectal cancer, for which about 50,000 Americans succumb each year. One of the things that has really fascinated me working in this research area is the kind of things that, small structures that you can see on a CT scan that are not really apparent on a slice image, like that stack of slices I showed earlier in the talk. And one of these structures is a muscle that runs the length of the colon. There's 3 of these muscles. They run the length of the colon. Here's one of them. There's another one here and another one here. And they help move things along the colon from the beginning to the end of the colon. And they're completely invisible to the naked eye on a regular CT scan. But by taking these images and turning them into a 3D model, it's then possible to take CT scans of the colon obtained on different days and use these muscles as markers to help twist the 2 different colons into perfect alignment. And so what you're seeing are 2 CT scans of the same person. This is with the person laying on their back, and this is with the person laying on their belly. And so these scans were done one after the other, but by using this muscle, we can rotate them into alignment, and we believe this will help improve the ability of doctors to find these polyps more accurately, because the doctor will see the polyp on both of these images, so there won't be any confusion about anything that might mimic a polyp. And I believe the ability to detect smaller and smaller things on these scans is just beginning. I think we'll be able to do this more and more in the future. I mentioned lymph nodes in the abdomen, and there's a lot of work on finding these lymph nodes more accurately. I'll talk a little bit more about that when I discuss the RECIST measurements. An area relating to the obesity epidemic in Americans is the measurement of visceral fat. People have 2 different major types of fat in the body. The visceral fat is the fat inside the abdomen, and the subcutaneous fat is the fat just under the skin. And it turns out that it's the visceral or internal fat that's very problematic and has been associated with things like colon cancer, diabetes, and other metabolic diseases. And in fact, one of the things we found by analyzing this fat, shown here in blue on this image, is that patients who have a lot of internal fat have twice the risk of having polyps in the colon. That was a study of about 1,200 patients that was done here and in collaboration with the Department of Defense across the street. Moving further down, the small intestine is an area of great interest to over 1.4 million Americans who have inflammatory bowel disease like Crohn's disease. And also, there are also some tumors in the small bowel. These are relatively uncommon. They have names like GIST and carcinoid tumors. The small bowel is very lengthy. It's about 22 feet in length and has a very rich blood supply like the one shown here. And just recently, we've been able to take these CT scans of the abdomen and make these really elaborate models showing the small bowel in blue and all the blood vessels feeding the small bowel in yellow. And I think what you gather from these animations is how rich the blood supply is to the small intestine and the great labyrinthine path of the small bowel in the abdomen. What we're trying to do is unravel that organ so that we're able to figure out exactly in the small bowel where an abnormality is. Hopefully in the future we'll be able to tell a doctor exactly where a lesion is so that it could potentially be removed. Presently what's typically done is at surgery a doctor will feel the bowel, trying to feel little tumors, and will then remove a big segment of the bowel because they're not really certain exactly how much is affected by the tumor. Hopefully this will be a way to make that sort of surgery more precise. Yes?
Can you also get a feel for the rest of the omentum, where the fat is distributed on the omentum?
Okay, so the question was about whether you can detect the omentum and how the fat is distributed in the omentum. So the omentum is a fibrofatty structure that lies in the front of our abdomen on top of the colon, and it's an area to which some tumors like ovarian cancer spread. And you can see the omentum on the CT scan, and very frequently we will see cancer spreading to the omentum. We haven't worked on that yet, but it is an interesting area. And in our work on trying to find the ovarian cancer metastases, we will try to look at that area. Did I answer your question? Okay. If there's any other questions, I'm happy to stop.
Same
same vein, can you comment on the limits of resolution? In other words, why can't you zoom in and go to the single cell level like Google Earth?
Right. So, as with many imaging technologies, there are often limits as you get to smaller and smaller structures. So there are machine-related limits like the quality of the detectors and the size of the source of the X-rays that's coming out, because if that source isn't very tiny, you'll get blurring, and so you won't be able to resolve very fine structures. And if the detectors in the CT scanner are too large, you can't resolve a structure that's smaller than the size of a detector, roughly, in the scanner. But the other issue is that to resolve smaller and smaller structures, you have to have an amount of signal that exceeds the inherent noise level that's already in the image. And when you try to see smaller and smaller structures, you're trying to find smaller and smaller signals, but unfortunately the noise in the image doesn't change. So the smaller the structure, the less signal. And in order to beat that problem, you have to use more radiation. So we don't want to increase the radiation to the patient, and so that's an issue with living things. Now, if you want to look at non-living structures, it is possible to get very fine resolution using special X-ray sources like synchrotron and monochromatic X-ray sources, and there are places in the U.S. that have these. I think Brookhaven National Lab has one, and these sites can do very, very high resolution imaging. So,
are you saying that at this point the major barrier is the radiation dose?
Well, certainly for in vivo imaging it is, and X-rays are destructive, so that's another thing that needs to be taken into account. But I'm not all that familiar with really microscopic X-ray imaging. I have seen some work on that area out of, for example, Brookhaven and other institutions. But it is a type of destructive testing.
Are there other questions?
How would you compare virtual colonoscopy with regular colonoscopy at this point?
Okay, so that's a good question. How do we compare regular colonoscopy and virtual colonoscopy? So there's been a very large NIH-funded study showing that the accuracy of virtual colonoscopy is equivalent to that of optical colonoscopy. So the accuracies are comparable, but there's a lot of other issues. For example, there's uncertainty about how frequently a virtual colonoscopy should be repeated. So right now, if you have an optical colonoscopy that's completely normal, they recommend you come back in 10 years. But right now they're recommending, because virtual colonoscopy is a new technique, that you come back in 5 years. So that doubles the cost, and it means additional exposure to radiation and an additional bowel cleansing. Another issue is right now we don't have enough trained people to do virtual colonoscopy for the tens of millions of Americans that need to be screened. So that will change as reimbursement improves. And then there are the economic issues about how do we pay for another screening technique. And in part, that has hampered virtual colonoscopy. So there are physicians in this area and other areas around the country that offer virtual colonoscopy, and sometimes insurance does cover it. I think in Maryland it does cover it.
So let me ask you, one of the problems of working with knockout animals, the preferable one widely used is the mouse. And it seems to me most of the ones that we turn to turn out to be embryonically lethal. Many of them at even late stages of fetal life. What's the role of imaging in detecting the nature or the dynamics of those knockouts?
There is a mouse imaging facility in the clinical center, or small animal imaging facility. So it is. They have a small CT scanner and a small MRI scanner, and I think they have a small positron emission tomography scanner and some optical technologies, and you can get your animal CT scanned or MRI'd, and they have been doing, I guess you would call them virtual autopsies on these animals to see how these different genetic abnormalities affect the internal anatomy.
Yeah.
Were you finished with your presentation?
I'm not.
No,
But I'm happy to answer questions.
Why, no, I wanted to hear him finish. He wasn't finished.
Please continue.
Okay, I only have another hour and a half to go, so. Okay, no, okay, so as you can tell, I'm moving down because now I'm at the prostate. So the prostate cancer imaging is a very important area. Prostate cancer is the second leading cause of cancer death in, it's actually the third after colon cancer. This is the prostate on an MRI scan, and the rectum would be down here. And in a very large clinical trial underway at the clinical center, they are doing a whole mount histopathology of the prostate after they do the prostatectomy or prostate removal. And they're identifying the areas that are cancerous on these whole mount images. And then what they're trying to do is improve the accuracy of biopsies. So what you may not know is that if a patient is suspected of having prostate cancer, perhaps because the prostate-specific antigen or PSA level is elevated, what they'll do is an ultrasound-guided biopsy of the prostate using random biopsies. So the doctor will put a needle into the prostate at multiple different locations to take anywhere from 6 to 12 or more different samples of the prostate. And they can't really see the internal anatomy of the prostate on the ultrasound. All they see is an oval gray structure. So they just try by random sampling. Of course, it's done in a regular sort of way, but they just hope that they will get the area with the cancer. So what researchers at the clinical center are trying to do is find ways to increase the accuracy of that biopsy technique, and they have in fact found that using MRI to guide the biopsies, they can substantially increase the success of these biopsies. So this is an area that I think is going to be very valuable in the future because of this epidemic of prostate cancer, which unfortunately hasn't decreased as much as we would like. So there's just a few organs left that I haven't covered. I'll just talk briefly about the bones. Cancer can spread to the bone. These are bones in the spine, and the cancer is this white area. This particular patient had prostate cancer, and we're working on ways to measure the volumes of all these prostate cancer or other cancer metastases to the spine and try to find ways to improve early detection of these and assess the response to therapy, a theme which I've described several times in this talk. Osteoporosis screening with bone mineral densitometry is also something that's of great interest. Osteoporosis is extremely common, particularly in older women, but also in men to a lesser extent. And in the course of a routine CT examination of the abdomen, it is possible to simultaneously evaluate the bone mineral density and determine if patients have osteoporosis. So hopefully this is something that could be more routine. Right now it has to be ordered as a special test. And there are other neat techniques, for example, taking the ribs, which have an oblique course through our chest, and straightening them out into this display here showing the ribs where any lesions in the ribs could be color-coded. For example, these metastases in red. So there's lots of things that we can do with these CT scans. And now that I said I would do a head-to-toe tour, so this is a disease, Proteus syndrome, which causes a disproportionate overgrowth of different parts of the body. And one of the parts of the body that is overgrown are bones. and these patients can get enlarged fingers and toes. Here's an example of an x-ray showing this enlarged finger. These bones don't just get longer, but they get wider. And they can also develop soft tissue tumors. This is called a cerebriform connective tissue nevus on the sole of this patient's foot. And you can see it's getting larger over time. And we've used MRI here at the clinical center to assess the size of this tumor, shown in blue here. The foot is here, and you can see the toes here in white. Okay, so that's the head-to-toe tour. In the last minute or two, I'll talk about RECIST, or Response Evaluation Criteria in Solid Tumors. This is used in cancer trials worldwide to determine whether patients are responding to treatment, and it's a set of rules describing how to measure the size of tumors. And one of the things that we're trying to develop are ways to measure these tumors more accurately. Right now, the tumors are simply measured by putting a ruler on the image and measuring the width of the tumor, like this tumor in the armpit here. But what we're trying to do is develop more accurate methods where we can measure the full volume of the tumor, and we're working with different oncologists here in the clinical center to try to assess that, and also to look for necrosis in these tumors that might tell us a little bit about the response of the tumor to therapies such as endothelial growth factor inhibitor medications. The final thing I'd like to talk with you about is the use of crowdsourcing and human perception. In many of the techniques in radiology, they depend on a human, a radiologist or other physician, to look at the images and to find abnormalities on these images. And as you might imagine, as these abnormalities get smaller and smaller, it can get harder and harder for a person, even a well-trained person, to find these. And what we've been looking at is the use of crowdsourcing over the internet to help us understand some of the human perceptual factors involved in improving our ability to understand information in images. And in one experiment that we did, we found that showing movies like this one flying around a potential abnormality, we could improve the ability of people to detect polyps like this one in the colon by as much as 10%. So there may be ways to improve our tests, and crowdsourcing is a very cost-effective and quick way to do this, and it leverages people out there in the community who are interested in participating in these experiments, perhaps because they have an interest in helping out with medical research. They may not be trained, they may not be able to help out in a hospital or a clinic, but by helping with these experiments, they may be able to help improve patient care. So I'd like to conclude my talk and thank you for your attention. This work was done by a number of scientists and physicians in my lab and in the Clinical Image Processing Service. It took advantage of help and collaborations from a number of different institutes and universities, and with help from many trainees through various fellowships at the NIH. And if you'd like to learn more, in the PowerPoint on the internet are my website where you can see various images and papers. So thanks very much, and I'd be happy to answer any questions.
Thank you very much, Ron. Yes, are there any other? Here, go ahead.
Very good talk, Ron. I enjoyed it very much. Your crowdsourcing slide, I'm very curious about that. Do you crowdsource to other expert radiologists? Is that who's the crowd that you source to?
The crowd are anonymous people on the internet who expressed an interest in helping out on perception experiments.
How can you trust that?
So that's a good question. We repeated the experiment and got the same results with different anonymous participants. So that's one thing we did. The other thing we did was we reran the experiment after giving these participants an examination. So we had them take a test. There were only 5 questions in the test. It only took them a minute or two to take the test. But we found that we could improve their performance simply by excluding people who just wanted to do the bare minimum.
So the comparative ROC plots you had, I presume that the black one was one expert and the green one was the Crowd's results? Is that what it was?
Yeah.
Yeah. Okay. Thank you.
Have you tried doing it with experts on Invisalign, like collaboration with radiologists?
Right, so the question is, have I tried doing that with experts? You know, it's very hard to get radiologists to do some of these experiments, and I had over 200 people do that experiment. The largest experiment I've been in with radiologists has had about a dozen radiologists. So to get 200 radiologists, I would probably I could go to an annual meeting, I suppose, and do it, but whether I could get them to do enough cases is really an open question.
Yeah, hi. Could you comment on the advantage you can get of combining molecular markers as well? I know the title implied that you were going to cover that a little bit, but you focused primarily on the anatomy.
Right.
But that's where you really get a lot of information, I imagine.
Right. So there's a lot of interest in developing new contrast agents that might help identify tumors or cellular processes that heretofore we haven't been able to detect. And that's a very active area of molecular imaging. There is work underway, for example, at developing agents that attach to metastatic implants and fluoresce under optical techniques. There are techniques that involve radiopharmaceuticals that can be used with nuclear medicine techniques like single photon emitted computed tomography to help identify tumors. And then those are the two most sensitive techniques, optical techniques and these radiopharmaceutical techniques. And then as you move to more insensitive techniques, then the next would be MRI. So there's quite a bit of research on tagging drugs or targeted agents with MRI agents that would go to particular cellular processes or that might get taken up in a cell, and then you could follow the course of that cell to a target organ. Ideally, it would be great to develop such a technique for CT. Unfortunately, CT is one of the less sensitive techniques, and you need much more attachment of the targeting agent to the target in order to see an abnormality. We have had some hints of ways to do that. For example, we have seen some contrast agents that will stick to polyps in the colon and might serve as beacons to alert us, for example, to detect flat lesions in the colon, which are very difficult to detect. And so that there is a lot of promise in that area.
So you commented on the limits of resolution of CT. What about the limits of resolution of ultrasound, MR, PET?
Right. So each of those technologies is up against that signal-to-noise problem, but in different ways. So, for example, I know with MRI, resolutions on the order of 10 microns or perhaps even less have been attained even in vivo in experimental animals. I'm less knowledgeable about the resolution for other techniques. For example, with radiopharmaceutical methods, resolutions tend to be relatively poor because these agents, you have to balance the radiation dose from the agent and the half-life of the agent and so forth, and how it's and how it's excreted. So I'm not quite sure about the resolution of that technique. Optical techniques, as you well know, can have very high resolution. That's what microscopy is. Ultrasound resolution tends to be not the greatest. There's a lot of issues with the scattering of the sound. It can be hard to get very high resolution. I'm not sure what the finest resolution is for ultrasound, but I have not seen a lot of work on very high resolution ultrasound, perhaps because of the scatter problem.
Any other questions? Yeah.
The question is to Dr. Bluemke. Could we measure accurately the possibility of a plaque rupture using coronary CT? This has been, done in the context of coronary calcium level. Could we measure or predict the rupture possibility of the plaque?
Yeah, we'd like to be able to predict the rupture of a plaque. Yeah, there are a lot of potential areas. We've had investigations where we look at the plaque components, the constituents. There's the anatomy, certainly. There's what is the plaque made of, and there's some components that look like they would be more prone to cause that plaque to rupture. So there's a lot of work in that area. I think that if you have a coronary abnormality, we can already start to assess some of the features, some of the tissue composition that's there that's likely to make that unstable. So that definitely is being done, and it's not a routine assessment, but it's part of the data that's collected currently. Yeah. Mm-hmm.
Some of these images were artistically beautiful, but it concerns me that, for example, when we were going down the windpipe, there's this shading and that doesn't come out of the raw data in the CT scan. That's some sort of software photoshopping kind of thing going on, right? And my concern is, even though it looks pretty, could it possibly lead to wrong decisions about what's going on, all that beautiful rendering of these images?
Well, any of these techniques have to be validated for particular clinical problems. So, for example, there's been quite a bit of work looking at the use of virtual bronchoscopy for guidance for biopsy. And as I mentioned, there's a commercial FDA-approved system for that. Similarly, for the virtual colonoscopy, there are a number of commercially available FDA-approved technologies for doing that. So the issue of the image fidelity and whether it shows the disease properly or not have been addressed in various clinical trials. These images that I've showed you are samples. I mean, virtual colonoscopy alone has been the subject of over 1,000 published papers over the past decade. So these things undergo a lot of investigation and discussion and critique before they get to the point where they're used by patients.
When you're going to doing quantitative measurements from these
Mm-hmm.
it can be distorted. Like in the early days of the ME scanners, there was this beam hardening artifact that really threw off the numbers.
Okay, so the question is about the accuracy of the quantitation. So again, that's an area that is a highly investigated area to make sure these measurements and these intensity values are accurate. So for example, for the osteoporosis assessment, it's very important to get accurate brightness values for the areas in the bone, because that's what you're using to determine if the patient has decreased bone mineral density, and there are established techniques for getting that right. So, and the scans are calibrated each day, so there's a lot of attention to that.
Okay, well,
Sorry. I have a question for either speaker. There was a slide showing the reduction in radiation exposure to patients who undergo these tests over time. Mm-hmm. And I was just wondering, out of curiosity, do you believe this reduction is due to better detection, necessitating less radiation in the first place, or better shielding in the machinery?
Well, there's definitely more attention amongst the CT scanner manufacturers at providing machines with improved sensitivity of detecting the X-rays and limiting the dose. But there have also been some more careful assessment of what's the minimum amount of radiation that's necessary to detect a particular person's problem. So there's been a lot of tailoring of the scan to individual patients that perhaps in the past was not done as frequently as we would like. And in addition, there's been a lot more assessment about what type of imaging is appropriate for a given patient. So there's been a lot of thinking about appropriateness criteria and using that as a way to reduce dose to the lowest dose is the test that doesn't need to be done.
Okay, well. Oh,
One more.
Here, use this, please.
I was just wondering, you said that these endoscopies and the colonoscopies are made with the CT images and you create, how does that compare to, I know now they have those pills that you swallow, and then those take images as they go down. How do those two compare?
Right, so the question is about the camera pill that is being used to look at that's mainly for the small intestine. The companies are trying to develop one to look for polyps in the colon, but so far it hasn't worked that well because the colon is bigger in diameter and the pill spins around in an unpredictable way, and they can't assure themselves that they've seen the whole surface of the colon. But they're improving it, and I imagine if they're able to, they'll figure it out. And maybe that'll be the way we'll be diagnosing polyps in the colon in the future.
Take one and call me in the morning.
Right.
Listen, I want to thank you both on behalf of all of us very much, and particularly thank you for coming. Thank you.